Hello everyone. Today my group and I will be discussing patients with special needs, focusing on child abuse, neglect, and family violence. We will be going over all of these key points that will help us in providing optimal care for our patients. In terms of domestic violence, the image below highlights how important it is to keep in mind how both men and women can be subjected to intimate partner violence. Abuse is a public health problem that can be physical, sexual, emotional, verbal, or a combination of all of these. The most prevalent abuse cases are child abuse, intimate partner abuse, elderly abuse, and abuse of disabled persons. Neglect are acts of omission by parents or caretakers that directly affect support, nutrition, adequate care, education, and failure to follow through on recommended health care. Neglect accounts for most all reported cases of maltreatment in the United States. Parents or guardians of abused children will often change physicians, but continue to see the same dental provider, which this gives us an opportunity to recognize any signs or symptoms of abuse, whether it is oral, visual, or any behavioral clues. 65 to 75% of abuse cases show physical signs of abuse on neck and craniofacial region, but oral health care professionals infrequently report maltreated victims. This could be the possibility of the uncertainty of diagnosis. Bruises caused by abuse typically are on non-bony areas, such as the arms, legs, or neck. There is a wide range of intraoral and extraoral injuries that are evident during a dental exam. Oral findings and implications that we may see with a child or an adult suffering from physical abuse intraorally could be a torn frenum, so either the lingual or labial frenum. They could have avulsed, discolored, or fractured teeth from trauma, gingival abrasions, burns or lacerations or cuts, trauma to the corners of the mouth, gingival contusion or bruising, palatal lesions and scars. Extraorally, we may see bite marks, multiple bruises, shaped or patterned injuries such as a belt buckle, black eyes, broken nose or cigarette burns, and inappropriate seasonal dress, long sleeve in summer to possibly cover up any of the previous mentioned. In neglect, intraorally we may see poor oral hygiene, rampant caries, early childhood caries, unmet dental or medical needs, delay or failure to follow through with needed care. Extraorally, we may see poor hygiene, poor or no parental supervision, caregiver is unconcerned about the child, and poor health literacy. With sexual abuse, intraorally we may see pediche on the soft palate, which may be a sign of forced oral sex, venereal warts on the lips, tongue, palate, or gingiva, venereal disease in pre-puberty kids. Extraorally, for sexual abuse, we may see difficulty in walking or sitting, or itching of genitalia. Some examples of oral manifestations of physical abuse is in this picture we see tooth avulsion of number 8 and fracture of number 9 due to physical trauma. In the next example for child neglect, we can see severe caries and abscess development from unmet dental needs and poor oral hygiene. In the first example of sexual abuse, we can see herpetic gingivostomatitis present in an adolescent. For the next example of sexual abuse, we can visibly see the palatal pediche that may indicate oral sexual abuse.
Next up is planning appointments. So prior to beginning the appointment, health questionnaires should include questions like, do you feel safe at home? Yes or no. This gives the opportunity for the patient to share if they're being abused. We also want to make sure that we provide a trusting and safe environment for the patient so that they feel comfortable. Appointments should be made in the morning, and we also want to make sure to schedule follow-up appointments. With patient communication, when we have a suspected case of child abuse, the clinician should remain calm and not overwhelm the child with questions. We do not want to pressure the child or confront the offender. Clinicians should interview the child and the patient separately. Communication should be conducted as a conversation and not as an interrogation to overwhelm the patient. Always ask open-ended questions to gather as much information possible. We want to be gentle, patient, and we do not want to force any procedure. And of course, most importantly, we always want to ask for permission.
Patient education, oral hygiene instructions. History of dental neglect is very common amongst this population. Due to dental neglect, patients may present with rampant caries, trauma, and oral pain. Patients may also present with poor oral health and improper dietary habits. It's important to note that poor oral health and improper dietary habits can impair a patient's learning and communication abilities. Therefore, we want to demonstrate empathy and be patient when presenting information. We want to educate the patient on the importance of oral health and good dietary habits, ensuring that the patient understands that sweet and acidic foods create a living environment for pathogenic bacteria. We also want to demonstrate appropriate flossing and brushing techniques as many times needed to ensure proper oral hygiene. We want to have the patient demonstrate to assess the level of their understanding. And we also would like to provide visual aids informing the patient of the etiology of tooth decay, gingivitis, periodontitis, tooth loss, and healthy versus unhealthy foods. Patient education and oral hygiene instruction continued. These two forms are very important for patient education purposes and oral hygiene. Canberra and nutritional questionnaire. These two forms will allow us to assess the risk for caries and the dietary habits of the patient. Another important bullet point, we want to educate the patient on the importance of fluoridated products. Overall, it's important to note that all of this information is favorable for the patient, but the real question is, will they retain the information all in one visit? Or will we, as clinicians, overwhelm them, right? So what we want to do in order to not overwhelm them and in order for them to retain the information is we want to tailor the information to the patient's needs. And then we also want to split the information throughout the appointments, right? And then going back to tailoring the information to the patient's needs, an example of that, let's say a patient presents with very low plaque index, but with a lot of white spots. What information will you present to this patient, right? Would you present information of the etiology of periodontitis when they don't even have gingivitis or periodontitis? Or will you explain the etiology of tooth decay, right? So what I would do, I would explain the etiology of tooth decay and also the importance of fluoride. And lastly, we want to present the information in words that the patients can understand. For example, when presenting information for children, we want to use simple words such as sugar bugs instead of carcinogenic bacteria.
Dexterity issues. Children may present weak bones and muscles and a sensitive oral cavity. Some oral hygiene recommendations include soft bristled toothbrushes, which minimize the discomfort and is more gentle on the tooth structure. Electric toothbrushes, which are the better option due to their limited dexterity or motor skills. Interdental cleaners, such as floss, interdental brushes, or water flosser. Mouth rinses to reduce bacterial load and plaque, and it is recommended to have a non-alcohol based solution to minimize irritation, and fluoride products to strengthen enamel and prevent decay. One of the most important roles as an RDH or a dental professional is being a mandated reporter to recognize and report signs of abuse and neglect, and we need to document all of that, and these include recording all clinical and behavioral findings such as lesions, their location, estimate of size, shape, and color. Document the whole conversation using full names, recording the reason for seeking or delaying treatment, and consent for clinical, photographic, and radiographic needs. Failure of a mandated reporter to report suspected child abuse leads to a misdemeanor in most states and is punishable by a fine and/or imprisonment. One of the other main roles that RDHAPs often provide is accessibility, and they're mostly mobile services that bring oral health care to patients with limited access to dental offices, which is valuable to patients experiencing abuse and violence, especially in nursing homes where we can catch institutional abuse. Also, outreach and education, where they engage in community outreach and initiatives to raise awareness on oral health and provide oral hygiene education, nutrition, and preventative care. Just as there are for oral findings, there are also behavioral findings and indicators to look out for as well. For physical abuse, the victim is usually frightened of parents or caregiver, afraid to go home, conscious of adult contacts, showing fear when others cry, and aggressive and/or withdrawn behaviors. For neglect, begging, stealing food, extended stays at school, constant fatigue, difficulty making friends, and antisocial. For sexual abuse, poor peer relationships, runaways, withdrawal, fantasy, or childish behavior, bizarre and sophisticated sexual knowledge. Behavioral modifications. Addressing patients facing child abuse, neglect, and family violence requires a sensitive and compassionate approach. Pain usually has a direct influence on behavior. The hygienist should be able to build trust, create a safe environment that is free of fear and anxiety, recognize the signs of abuse and neglect as seen on the previous slide, observe changes in behavior such as facial expressions, crying, complaining, and body movement, and encourage open communication.
Question 1. True or false? 65 to 75% of abuse cases show physical signs of abuse on the neck and craniofacial region. And the answer is true. It's important to keep in mind that bruises caused by abuse are typically visual on non-bony areas. Question 2. True or false? Parents or guardians of abused children will often change physicians but continue to see the same dental provider. The answer is true. This gives us a unique opportunity to recognize any suspicious activity of abuse or neglect.
Question number 3. True or false? When abuse is suspected, we want to ask as many questions possible to the point where patient feels overwhelmed. The answer is false. So we want to ask questions to get the information, but we don't want to overwhelm the patient. Question number 4. The clinician should interview child and patient separately. True or false? The answer is true. So we do want to interview the child and patient separately to hear both sides of the story.
Question 5. Role as a mandated reporter include A. Recording all findings, B. Documenting conversations, C. Recording the reason for seeking or delaying treatment, or D. All the above. The correct answer is D. All the above. As a mandated reporter, it is important that we document everything because it will be useful when we report it to the appropriate authorities, and also making sure it's also part of their patient record because it is a legal document.